Hi everyone. My name is Alex Wong from Shirley White Ability Lab. I serve as a scientist working there. Talk a little bit about history. Back to 4 years ago, when we talked about trying to prepare a new cycle for the SCI model system, we are very fortunate to have Dr. Rimmer come to SLA Lab to talk about some idea what we can do for the upcoming model systems. So as you can see today, I try to present one of the site-specific projects that right now is ongoing by working with the team, with myself and Arun, he's a PT, also the co-PI of the project. We also have a postdoc, Sarah, and a research assistant, Anasu, working on this specific project. So the overall team involved other people that I list out here. Their support are very important to help this project moving forward smoothly. Regarding the project, at the time when we learned from our patient, lots of our patients talk about, hey, after hospital discharge, they start to thinking about what they can do to become more wellness. At Chicago, we also have something like the Lakeshore Foundation. We have the accessible gym, but some of our people living with SCI thinking about they don't want to travel, they don't want to go to the downtown, difficult to get parking. So they try to ask our physician and PT what they can do at home. And then we're thinking about home-based exercise program, but you also are aware when the people do exercise at home, they also have some difficulty, right? So we got some consultation with Dr. Rimmer. Dr. Rimmer only give us some keywords, thinking about the exercise guideline at that time point. And then we try to look at what is exercise guideline for SCI. We are aware the UBC, the Dr. Catherine Janice Martin, her team developed the SCI specific exercise guideline about 1999. And then we thought that that may be something we need to work on, help people to do exercise at home and able to meet that exercise guideline even though they do the home exercise program. So as a result, we harness the technology, we're using the tele-rehab, we try to thinking about we should do something on the app, try to help people to do more exercise, engage them, even though they are at home, they can still able to do exercise. So, as you can see the slide here, there's two guidelines. One for the more general fitness, which is on the orange color. There's another guideline that more try to reduce the risk of type 2 diabetes or heart disease. That would be more rigorous. So our goal for this project is more try to help people adherence to the orange guideline, the overall fitness. So the guideline you can see here is on each week, the people with SCI try to do 2 times exercise, at least 20 minutes of the moderate and rigorous exercise, and also do 2 times per week for the 3 set of major the strength training exercise. So you're not surprised, many people with SCI is unable to meet the guideline. So if you look at the graph on the right, so only 12% of people with SCI able to meet the guideline. And 44% of people with SCI, even though not do any physical activity. Of course, you can argue, even though mainstream population, people without disability, is also unable to meet the CDC guideline as well. As you can see here, yes, only 23% of people without disability could only meet the guideline. But you can tell, people with SCI, they're even lower. Only 12% of people able to meet the exercise guideline. So we need to do something to help them to meet the guideline, right? So what we do, we're thinking about home-based exercise program at the beginning, but we also know that there's so many different barriers, right? So we know some psychological, personal factor. The people may not have motivation to do exercise. Even some people have motivation to do exercise, but they're thinking about, if I need to go to the gym, that means I need to pay the membership. That might be expensive. The cost always to be a factor. Even though I want to go to the gym, but sometimes I need to find out the care partner to go with me or find the way to go to the gym, even though which is accessible. So transportation factor is also one of the barriers for the people with disability go, right? This is all we know. So sometimes we also know that lots of our patients, after the injury, They are afraid to do exercise. They don't know how to do the exercise. As a result, we're thinking about the professional involved is still very important. As a result, you can see our program not purely develop the app. We also try to create a customer exercise program for each of our participants. So to solve all the problems I just mentioned, we're thinking about using the app designed for home-based exercise program might be a solution, which is a low-cost solution that can try to reach more people. For the overall exercise program, we try to develop have three major components. The first component is what we call the customer exercise program. We invite the participant at least come to our SRA lab for one time. Our PT try to do the physical performance testing to assess what kind of muscle and functioning people can do so that we can prescribe the exercise that people can do into the app. So the people with disability come to our lab one time, about 1 to 2 hours, try to do some baseline assessment. We try to prescribe the exercise based on their capacity. We involve some activity, even people with paraplegic, they still able to do some kind of exercise. So the second component that we have in our program is we spend lots of energy to design our app. Our app have lots of behavioral change technique. If you are aware, there's a behavioral change taxonomy developed by UCL, Dr. Michi. She's talking about 93 behavioral change technique that we can implement to make one behavioral change. We try to apply some of the behavioral change as you can see here. The goal for using the interactive app is help the people set up the goal. We make sure they have some action plan to do the exercise so that we try to monitor what they have done, what have not done, in order to help them to achieve their goal. So finally, we're thinking about some people may work well, even though we give them an exercise app, but some people may need some lunch to push them a little bit. So, but we know that not all the people need the coach. So in our M3, we're actually using an innovation design, called SMART, try to support the people who need additional lunch by giving some MI coaching, as you can see. Of course, based on the behavioral change theory, we want the coach help them to problem solve because we have the patient talk about, even though we have the equipment sent to their home, they still have some struggling on how they can do the exercise. We're thinking about that coach, that MI-based training coach can guide them to problem solve some of the barrier when they are doing exercise at home. So for the overall project, we have 3 aims. The focus of this presentation will be the first 2 aims today because our SMART trial is still ongoing. But the first aim is we try to do some implementation science work, try to guide how we can build a dream app for the people with disability. So the first aim is try to build the app. Our second aim is to test the usability of that app. The third aim that is ongoing is try to compare whether our interactive app would be better than the regular app to improve the exercise adherence for people with disabilities. So we're using a model that may be quite familiar with you all called CFAR, which is an implementation science model, try to help us to identify not only the intervention factor, but also some contextual barrier that might affect people using the exercise app at home. So we're using this model, try to identify 5 major domain barriers, including the intervention characteristic, including the inner setting, which is in the case would be the home, and also the outer setting, that means the hospital, the community, what kind of factor would affect people using the app. We also talk about some of the individual and process barrier that might affect people using the exercise app. What we do is we have the 2-step procedure. The first step is we do the expert panel. We ask the clinician what 3 major factors do they think that most important to be success of our exercise-based intervention. We do ask them to do the ranking and then pull from the CFAR model. They have lots of different constructs. We try to explain to them what are the major constructs considered under the CFAR. they finally come up with their ranking, and then we try to summarize. As you can see here, the top factor they talk about is the adaptability. That means they want the exercise program can be more tailored and customized to each individual needs. That makes sense, right? So, and also they're thinking about the capacity of the app, and also the evidence base given from credit resources are all important factor when they thinking about when we decide the exercise app for our patient. So we consider all the factors suggested by our expert, and then we decide the interview for free population. So we actually did 8 focus group, including 23rd subject with SCI, 6 caregivers, as well as a clinician to come together, run 8 focus group to discuss the barrier we identify from the expert panel, to discuss what kind of major factor or features that we need to consider when we build the app. So that may be too small for all of you, but you can see we identify some major theme identified from this focus group. Personalization is always the top content mentioned by our participant. They also like the information from credit sources that, as I mentioned here. So you can see here that may be too small, but the first column on the high-level theme are the major theme identified from our focus group. But something very interesting here is compared with the clinician, caregiver, and SCI participants have very different focus. So they look for very different stuff, but we consider both. We work with our vendor, the PT Pal, to consider what kind of features we can change based on their suggestions. So this is the process how we, based on the comment given from our patient clinicians, and make some suggestions how we can make change on our app. So of course we cannot change everything. Based on our budget, based on their prioritization, we finally come up with some major features that we can make adapt into our protocol too. I try to show you the app, how it looked like after the focus group. So as you can see here, so we have the different activity can be prescribed to our participant. We have the baseline assessment done by our PT, and then we prescribe the relevant exercise to each of our participants, and then we set up into the program. Something I remember, one of the PT said, if you really want us to using your app in the future, remember, I only have 5 minutes for you to set up the app for my patient. So that's why when we do the back end, we actually create the library with lots of exercise. The PT can just scope the exercise into the app so that they can automatically load all the exercise into a specific patient. So it's actually less than 5 minutes. Right now, maybe if the PT know our system, he could actually choose an exercise by 2 minutes to each patient. So, and also we have some comment from our participants saying that, hey, Alex, you are so old-fashioned. You only give me the graph. Right now, all the people using video to learn. Oh, that's true. So finally, we come up a version, instead of giving the graph how to show exercise, just like what we did in our clinic, we actually put into the YouTube video, try to guide the people doing exercise. And one physician suggests we need to have people with spinal cord injury to be the model. So we do that. We invite a field model with different level of ability, try to do different exercise, and then become our model and put into our back end. So of course, some behavioral change technique, we also able to monitor the people activity, set up the goal. The people can see what exercise, how much exercise they need to do on that day. We also using some of the self-report technique through the cell phone to assess their pain level when doing specific exercise, so that this information can guide our PT and the future coach to adjust the exercise program. Of course, some participants also like some education information. For example, even though the basic information, how important of the hydration, the people still want to learn. So we have some education information can be prescribed through the app. We also allow our patient to leave questions on the app, even though we do not directly respond to the patient immediately, but our PT and the project staff can respond to the question during the office hour on the other 2 days, on our other days. So we're also able to do some personalization. The people can set up the timer, want to set up the silent, whatever they can do from their profile page so that don't disturb their daily life. Okay, after our version 2 prototype, we try to test a group of subjects with spinal cord injury to do something we call the usability testing. So very simple. What we try to do is we have the app, we invite the people try the app for 2 weeks, and then give us some comment how we can make an even better app. Of course, we're using some self-construct questionnaire, not self-construct, it's self-report questionnaire to ask about the app usability and stability. So we're focusing on some domain. As you can see, the first 3, feasibility, stability, and appropriateness, are all from a implementation outcome measure developed by York, Washington. We're also using an instrument focusing on the app quality called UMass to assess different domains of the app quality in terms of engagement, functionality, indices, information, and the overall impact. So we don't do enough. We only invite 12 participants with SCI. They have different level of mobility functions, and then come to try the app for 2 weeks and give us some suggestions how we can do a better job to improve the usability. So overall, among these 12 subjects, you can see most of the weighting in between, from the range on 1 to 5, they are more likely between 3.5 to 5. You can see the purple color, the higher weighting in terms of the 3 FIM, AIM, and IAM instrument. We also see lots of the scoring in between 3 to 4, 4 to 5 on the weight on the app quality. We do 2 parts. We do some quantitative descriptive survey. We also do some focus group interview with our participants. We try to ask them what they like most, what they don't like most. Of course, similar finding found out from our previous phase. The most people like our video structure, and also the exercise prescribed by the PT, that part they like the most. So we keep working on the app, and finally we have some new theme identified. So of course the app function is the key. The people thinking about if the app is not able to meet the goal for help people doing more exercise is useless. So that we think about that theme is the key. Lots of the suggestions given by how to make the app more engaging. Even though very small features, but you can see on our version 3, we really integrate the suggestion to make it better. So this is the summary list suggested by our participants. They give lots of suggestions how to make the app even better. Of course, we talk to our PT Pal vendor company to talk about the timeline and budget. We finally able to make change on most of these features. Not all, but lots of them. So as you can see, very similar, but we really do some change. So the people really like to see their progress, even though on every aspect. So as you can see right now, for the activity, the workout, the people can directly track what exercise they do. They can also see the instruction more clearly, how to do different exercise. We keep the monitoring part because the people like a lot too. Instead of ask the pain question, right now we change a little bit different to ask about physical exertion. So people tell us, even though they can live with the pain to do exercise, but they really want to know how much exertion exhaust them to not doing exercise. So the PT right now using this information to guide, adjust the exercise program. Same, doesn't change a lot. We still keep the communication between our research staff and the user. We also leave the information page for us to upload some useful information to our participants. Okay, after we done our usability, we went to the formal stage of testing the app. So we're using a design called Smart Design because, as what I taught at the beginning, not everyone need additional support. Some people can just using the app we design. So we come up with a design called Smart. So how we do for this is, as you can see, at the beginning, we invite our participant to come to our hospital to do a functional performance testing to assess what kind of exercise each participant can do. So after that, so we randomize the people into 2 groups. So for a 3-month intervention, for the group 1 is the app without the features I just suggest. So they don't see the EMA, they don't see the monitoring features. So compare with the group 2, which is the app that we developed. So we try to test each week. We have the exercise adherence web form, try to assess how many exercise people can meet per week. If the people able to meet 6 out of 12 weeks of the exercise guideline, we define these participants able to meet the guideline. But someone, they cannot do half of the 6, that means 6 weeks out of 12 weeks, cannot meet the exercise guideline. What we can do is we provide them additional support. We give them the MI coaching to further support them to do the exercise. Of course, we further randomize our trial by someone only give 1 MI section per month, someone give 2 per month to see any dosage effect on the MI coaching. So this is the design, what we are doing. Right now, we have about 14 subjects enrolled to our study. You may be asking how many people able to meet the first exercise guideline among that 14, right? So we don't really have 14 people all complete the phase 1. We have about 11 subjects. Interestingly, so we have about half of the subject able to meet the exercise guideline by using our app. So which is actually more than we thought, because we think about most of the people unable to meet the guideline. So why our app so powerful? Of course, just 6 people cannot tell much, but we're still working on the project. Hopefully can share more results in the future. Just give you some idea, because this is a proof of concept study, we not really test many like health outcome. Our primary outcome is the exercise adherence guideline. So that's why you can see the primary outcome is the percentage of adherence. But we also collect some of the health outcome, like the change in fitness, some of the quality of life measure from cycle. We're also using our smartphone. The PT Pal can extract all the digital market data. Arun is a AI guy, more interest on analyze all those digital market data. We also collect some of the information, but I'm more traditional PTOT researcher. I collect the physical performance testing as the major secondary outcome. So this is part of our MRSIC project. You can see our newsletter try to promote our own study and also the mentor study led by Dr. Rima. We promote through our MRSIC. So that people can learn from what existing study clinical trial exist from our organization. So thank you. This is our team that we work together on different kind of projects to benefit people with disabilities. Thank you.